This is Heart Rhythm TV, and I'm Daniel Alyesh here with HRStv Journal Club. And we're discussing today the results of the VANISH2 trial, presented last year at AHA and published late last year as well in the New England Journal. And for that reason, I'm joined today by Dr. John Sapp of Dalhousie University in Halifax. Welcome.
Thanks, Dan. Nice to be here.
Well, I really enjoyed your study. Our techniques for VT ablation, whether it's ILAM mapping, high density mapping, it's only improving. And by the same token, understanding its relative value or relative impact to antiarrhythmic medications is terribly useful. We've already seen those data pan out in atrial fibrillation, and we're very, very grateful for you performing this procedure in the VT population. So to start off, I want to summarize for the viewers your original VANISH study, published in 2016, a similarly sized study which studied antiarrhythmic escalation relative to VT ablation. And there are a bunch of sub-studies that have been done of it. It demonstrated improved primary outcome with ablation relative to antiarrhythmic escalation in ischemic VT. This study takes it to the next level. Around 410 patients randomized in a 1-to-1 international randomized clinical trial, studying antiarrhythmic medications relative to VT ablation as a first-line therapy. And so I wanted to, first I've asked you, what did you learn overall? What were the major findings of your study?
Sure. Why don't we run through them? So we defined a primary outcome of the study as a composite of death at any time, or after a 14-day treatment period, appropriate shock, VT storm, or sustained VT below the detection of the ICD that brings the patient to the emergency room and gets treated there. So all of them we thought important clinical outcomes that are all related to things going badly and to patients' quality of life. So in that composite, we saw a 25% reduction in the hazard ratio of a 25% reduction in the rate of that primary outcome. So delay in the time to first of any of those events. And that was made up of each of the components. I think you've got the primary composite showing, and also appropriate ICD shock, which mirrored that same reduction in the event rate, although independently not statistically significant. And also one that was independently significant was a reduction in that sustained VT below detection of the ICD. Now that made a relatively small contribution to the overall number of events that made up the primary outcome, but quite a big effect in that one component of the primary outcome.
I think these data are incredibly valuable to the clinician trying to make a decision about when to pursue VT ablation. Tell me a little, reading between the lines a little bit, tell me a little bit more also about crossovers. Who crossed over to ablation? Who crossed over to medications? Give us some insights there.
Oh, that's a good question. So we haven't really dug into the statistical effects of that, especially after patients experience a primary outcome. But if you look at what happened to patients after they got enrolled, we analyzed it on an intention to treat basis to preserve the benefit of randomization for understanding, the therapeutic choice and the consequences of that. But of the patients in the ablation arm, 3 did not actually go on to get an ablation for a variety of small reasons. One withdrew consent, another was found to have an LV thrombus, another had an unsuspected allergy to heparin, and then the patient and the clinician decided they didn't want an ablation. And on the other side, in the ablation arm, 17 patients actually eventually went on to get antiarrhythmic drugs without having experienced a primary outcome. So 6 of them for atrial fibrillation. So, quite a bit after randomization. 2 got put on antiarrhythmic drugs for PVCs, like not what you want when you're running a trial for this kind of thing to happen. But, we're experimenting on human beings, not guinea pigs, so you can't control everything, you know. And then a smaller number had some VT either during the treatment period in 5 patients, or a couple of patients had late VT after 4 or 6.5 years, not meeting a primary outcome, but enough that the clinician patient decided they couldn't go without some kind of treatment.
Very helpful. So a fair number of crossover in the direction of ablation for various reasons.
Yeah, but there were even more that would have received either therapy after experiencing primary outcomes. So even though the ablation arm only had 203 patients in it, they received a total of 240 ablation procedures.
Okay.
And then in the 213 patients who were randomized to antiarrhythmic drug, 79 ablations were performed. So like, more than 35% getting an ablation at some point afterwards. So sort of that doesn't so much affect the primary outcome
Sure.
or this time to event analysis, but it does affect, like it does reduce probably the distinction between the groups in terms of burden of arrhythmias experienced by the patients.
Got it. And then, performing an ablation carries with its own safety issues. Antiarrhythmic drugs and toxicities carry its own safety issues. Can you elaborate for the viewers a little bit the differences in the safety endpoints between the two?
Right. Yes, I can. So it's very hard to assign blame for was some adverse effect due to the drug or was it due to the ablation? So for ablation, adverse outcomes and safety endpoints, we looked within 30 days of the ablation and said, any of these occur, we listed it. And so a couple of highlights from that. One patient died from a stroke. That was very likely, I think, peri-procedural. Another patient had sepsis and pneumonia, and that it's a little bit less certain, but that was a death within 30 days. There were like 1.5% patients experienced a stroke within 30 days. That's a little on the higher side than I would like. But if you look at all ablations in the entire study, it's just below 1%. If you look at that rate of stroke in the entire number of ablation procedures that were performed. And then there were the usual sort of smattering of pseudoaneurysm or bleeding and so on, but those relatively lower. Now the drug arm is more complex because those safety outcomes tend to be pushed out over time. So, a few side effects might happen early, but typically they accumulate over time. And we have not yet analyzed that sort of time course of when those things occur, but we did see like 22% of patients in the antiarrhythmic drug arms stopped or reduced their dose because of some kind of adverse event. And those were all blind adjudicated by, by a committee that didn't know how they were randomized. So there was hyperthyroidism was a big one, about 3% or so, about 3% liver dysfunction or so, and 3% lung, like fibrosis or pulmonary this is or that's. And the one death that was attributed to be due to drug was thought to be due to pulmonary fibrosis. And then there was, like 4% with GI intolerances that had to stop the drug, and 2.5% liver enzyme elevation that the clinicians felt they needed to cut back on that treatment. And then similar number with neurologic symptoms of for different variety. So those all add up, and we have not yet looked at the time course. It's really difficult to compare safety in the two because not all adverse events are created equal. You can't just compare numbers 1-to-1. I guess, Dan, it might be worth thinking about that most of those adverse effects that that we just ran through are things that we usually think of as amiodarone potential toxicities. Again, we haven't yet got the analysis of this completed, but only half of the patients in the trial were in the amiodarone eligible arm. So those events are clustered mostly, I'm guessing, are going to be, we'll find, are probably mostly clustered in the patients that were treated with amiodarone.
I completely agree with you, John. I think, one of the great things about your study is how clinically applicable what you're describing is. I mean, I think, hearing the toxicities, and we're going to dive into some of the antiarrhythmic drug differences, even though the trial wasn't necessarily designed for that. But, over time, it's my philosophy, the patients on amiodarone eventually develop something. It's a subset of patients that I feel comfortable leaving on amiodarone. And so, ablation safety, not perfect, but actually relatively good in the realm of VT ablation. And then a cumulative effect of antiarrhythmic toxicity over time. But I want to take us to our next slide here, talking about the inclusion criteria. Because I think this is really important for people trying to apply your study to their patients in the clinic. Because I know firsthand people approaching me saying, "Hey, I want to apply these data. I think this is a big deal for my VT patients." And I think I'll just kind of very briefly summarize those: sustained VT, having requiring direct current cardioversion or pharmacologic cardioversion, 3 episodes of monomorphic VT, one of which is symptomatic, requiring ATP, or 5 asymptomatic ATP or 1 appropriate shock, or essentially VT storm. Now, this is, for people who are sitting in clinic, it's not, there is a certain nuance to this and a certain amount of VT that must happen for them to see this benefit. John, will you elaborate on how you chose these inclusion criteria?
Yeah, that's a good question. So we wanted to include patients that most people would feel it was reasonable to take the risk of a procedure. I mean, if you take low risk patients, they're going to have great outcomes, and all you're going to have is safety concerns, and you won't really see any difference between your treatments. So we wanted to pick enough VT and enough symptom burden and patient burden that we thought, patients and clinicians would agree, yeah, it's time we should do something here. So what we did is we did a national survey of cardiac electrophysiologists and kind of gave them a smorgasbord of when would you intervene on a patient. We kind of graduated the amount of arrhythmia and then used that to develop this threshold for treatment. And simultaneously, we performed patient focus groups. So we had 2 different focus groups of patients with lived experience of ventricular arrhythmias and ICD shocks, and in one group, and the other had all of that plus a history of experience with antiarrhythmic drugs or ablation. And we did a semi-quantitative analysis of their experience and try to glean from that what patients thought was enough VT to warrant treatment. And so that's where we arrived at this list. In reality, I think the big ones here are, enough ATP that you feel you got to do something, VT storm, an appropriate shock, or the patient comes to the emergency room and they're in VT, as oftentimes they've been in it for a few hours by the time they get there and things aren't necessarily going very well.
Sure. No, I think this is all clinically appropriate. And, I think the right, significant amounts of VT that our threshold is met. So I'm not surprised this is a consensus opinion, because I think it reflects a lot of people's threshold in experience centers. Now I want to dive into the differences, and this is from the supplemental materials. And I recognize that, the study wasn't necessarily designed to understand these differences, but it's fairly glaring in these curves, the differences between sotalol and amiodarone. Can you elaborate for the viewership?
Yeah, absolutely. The inclusion of sotalol, we really agonized over whether to include sotalol as a treatment. And this too was based on our national survey and the patient focus groups. Like, a lot of patients just didn't feel it would be acceptable to only have amiodarone or ablation as an option. The healthier patients with better ejection fraction, whom any of us would feel more safe, that sotalol would be a reasonable option, even though we know it's less efficacious. It's clinically more reasonable than amiodarone for some patients. That's why we designed the trial this way. And so it turned out that about half the patients were in the sotalol eligible stratum and half were in the amiodarone eligible stratum. And what made somebody eligible for Sotalol was they couldn't have an EF less than 20. They couldn't have class 3 heart failure, had to be better than that. And they couldn't be VT storm. And then, a few other contraindications to Sotalol. So that's what really defined these two groups. So the amiodarone eligible stratum is a sicker patient group, worse ejection fraction, worse heart failure, or VT storm than Sotalol. And we saw the difference in the Sotalol eligible stratum in terms of efficacy was quite marked, with a hazard ratio of 0.64. So a 36% reduction in the rate of that primary composite outcome. And the p-value for that was quite significant. But in the amiodarone eligible stratum, the effectiveness was more similar. The hazard ratio still, point estimate of the hazard ratio, point estimate of the effect still favored ablation, but not by as much. And that, as you can see from the curve, was certainly not statistically significant. So it's kind of interesting. If you were to superimpose these two graphs, I think you'd see that catheter ablation may be less effective in the amiodarone eligible stratum, probably reflecting larger scars, worse burden of VT, bigger infarcts, worse heart failure, and that the drug looks a little bit more effective than Sotalol. So that's what brought those two curves together, I theorize. And then we have to balance that. Sorry, we probably have to balance that against, all of the drug risks are probably concentrated mostly in that right-hand graph. Again, we haven't analyzed that, so I'm guessing at this point, but we will be looking at that in the next few months.
Yeah, well, we're going to look forward to that analysis. I mean, and so to summarize, Sotalol in a less sick population, amiodarone in a sicker RVT burden population, Sotalol doesn't appear to work as well as ablation, clearly. And then in a sicker population, it seems ablation still outperforms the drug by a less significant margin, but you run the risk of more toxicities over time with amiodarone. So we got to balance all these data, and we look forward to your analysis in time. So I wanted to get a little technical now with VT ablation. I think it's very interesting, some of these technical results that you find. You chose to do a pre and post induction, which I'll editorialize, I am still very much doing, even though I do a functional assessment of the scar. But tell me about your decision to do pre and post testing. What factored in?
Yeah. Well, I guess I'll start by saying, we designed the study in 2015, 2016 kind of time frame. And we kind of got our whole steering committee together to kind of approve what would be an acceptable ablation protocol. We want to deliver as homogeneous a product as possible, but at the same time, herding cats is difficult. So everyone's kind of got their own thing that they do. So we defined the protocol that you would do induction testing, so what VTs, at least some of the VTs that you're chasing. And then if it was a small scar, you could consider just burning everything that you could see in the scar, all the late abnormal ventricular signals that you see, or sites that capture with delay or fragment or decrement. But in larger scars, if you try to burn an entire big old anterior infarct, you're probably paying lots of attention to sites that in the end aren't going to make a big difference for the patient, and you're sacrificing time that you could be spending on higher value targets. So that's why we had the induction testing at the beginning. If you know that there's a VT that's coming from that anterolateral part of that big anterior wall infarct, you want to make sure that you spend a good amount of time looking for substrate proximal to that exit, anything that might be contributing to that VT, even if you can't map that VT in particular. And if you do happen to have mappable sustained monomorphic VT, I still like to target, not just because it feels good to terminate it, but because I want to be sure that I want to be sure it's gone. If we can do that, I think I like to have that that know that we've terminated it, rendered it non-inducible, and wiped it out pretty well. And then induction testing at the end, not that gets skipped not too rarely. I think mostly because of patient fatigue and operator fatigue, or maybe because you've made the decision, hey, I've ablated everything that I can find, and no matter what I find on induction testing, I'm not going to do any more for patient safety or whatever. So that does get left out, more than I think any of us want to admit. But yeah, we did do that, and we studied that in VANISH the first, and saw that a negative EP study at the end does predict better outcomes. We have not yet analyzed that in this study.
Yeah, I think, inductions carry risk, but I think if you understand who your patient is, understand how aggressive you're going to be, I think it can be very helpful, especially in the post-testing situation. So, I think you alluded to another concept I want to ask you about, which is understanding the scar and sinus rhythm. Isochronal late activation mapping, waddles, extra, S2, S3, understanding channels in the scar prior to doing inductions. I think that this mechanistic understanding, now, while there is a debate of homogenation versus more mechanistic focus, I think a lot of us are doing more of that. So are you able to kind of share with me the breakdown in the study of how operators chose to either homogenize or functionally treat scars at all?
Well, like all I have on that is shown in the table that you've got up there. So it's a big job to try to tease out exactly how each procedure was done and then try to relate that to outcome. But what I can tell you is that 100% of ablation procedures did use substrate mapping. The one where I guess you can see that 99.5% of procedures use substrate mapping, and that one is because I think that patient, they aborted the procedure or something. So everybody got substrate mapping, and then they used a variety of pace mapping, activation, and entrainment mapping to specifically target induced VTs, or VT that that might have been, as we often say in our lab, take out that VT and all its friends. So
Yeah.
look for other substrate that might be nearby and looks like a high value target.
I take a focused approach up front to know where I need to go first with inductions and ILAN, but I actually still, I'm Frank Bogan's trainee, so I take it to task after that still, as long as we do it safely. Question I have for you, because this is not uniformly done. Are you able to share with us high density mapping and high density mapping catheter? What percentage of these patients receive that versus an ablation-based mapping?
Yeah, Dan, that's an interesting question, and we don't have it yet. That's probably going to end up on our list of sub-studies. I must admit, it's probably not right at the top of that list. But digging into what catheters were used is a bit challenging. We do have kind of defined case report forms, so we actually do know what catheters were used. But yeah, I don't know the answer to that yet. We'll be interested in looking at what clinical factors predict both safety outcomes and procedural success. So we do have a couple of planned sub-studies that will specifically look at some of those questions. Yeah.
So, final question for you. People are gonna look at this study. They're gonna say, okay, ablation is a first line. I think this is compelling. Now the ablaters in your study and the ablations performed in this study, relatively good outcomes, good efficacy and safety. I'm going to be honest and say that my perspective is not all VT ablations are created equal. I think there's a volume component to doing a good job and to understanding the physiology. What were some of the requirements for VT ablaters to participate in this study, just as people are trying to apply this for their own clinical practice moving forward?
We didn't impose some kind of, you have to do this certain number per year or anything. It was more, frankly, it was a lot of the same folks who had taken part in VANISH1, who are experienced clinical investigators and also, experienced clinicians interested in looking after patients with VT. It was mostly a Canadian study. We had a couple of American sites and a couple of French sites. But to come back to your main point, like it is a procedure done by human beings, by a team, by an ablationist, an electrophysiologist doing the procedure, but also by their whole team and their hospital that all have to support that procedure. So, that can absolutely vary by site and by experience and skill. But I guess what we hope is that because it was at 22 sites, that supports the generalizability of the findings. You might find, as I say, your mileage might vary, So if you're at a particularly skilled site, maybe you'll have even better results with ablation in comparison to drug therapy. Whereas if you're less careful with the procedure, maybe it won't be as good. So I think it behooves us, to do the procedure well and well-intentioned and, take it seriously. There's less skill involved in prescribing the drug, but, monitoring patients for safety, that is something that physicians need to do carefully as well.
Oh, great. Well, thank you very much. I mean, I think this is a tremendous step forward for our understanding of the role of VT ablation versus drugs in ischemic VT.
Well, thanks, Dan.
And, I look forward to, I think we've outlined a lot of different analyses that are going to be forthcoming from these important data, and we look forward to learning more.
Well,
And thank you
thanks very
all.
much. We'll keep working on it.
And thank you all for tuning in to Heart Rhythm TV.